This PowerPoint presentation will be about hematological disorders. After this module, you should be able to demonstrate an understanding of care for patients with hematological disorders. Heme disorders will consist of red blood cell disorders, bleeding disorders, white blood cell disorders, and lymph disorders. What is anemia? So anemia is defined as having a low red blood cell count, low hemoglobin, or both. So this results in reduced oxygen carrying capacity of the blood and decreased perfusion. We're going to be looking at a few very specific anemias, like iron deficiency anemia, B12 anemia, which is called pernicious anemia, folic acid deficiency, sickle cell anemia, and aplastic anemia. So what causes anemia? So there are many causes. The big ones we see: blood loss, inadequate red blood cell production, increased red blood cell destruction, or some sort of deficiency of necessary components, meaning that you have a nutritional deficiency like iron, folic acid, erythropoietin, which is produced in the kidneys, and B12. So we're going to look at these and go, we will have anemias because we don't necessarily have all of our nutrients. So when we build our red blood cells, we have pieces missing, so then it can't function very well to transport our oxygen through the body. There are some risk factors that make it more likely that you would have anemia, and that is a situation where you would have acute or chronic blood loss, rapid metabolic activity, increased hemolysis, inadequate dietary intake or malabsorption, bone marrow suppression, and age. So one thing we don't have listed under there is your gender, but we will put that under the chronic blood loss. Women who have very heavy menstruations would have that chronic blood loss, and they would fall under that category. So clinical manifestations of anemia are going to vary. So the lower the blood levels, the more manifestations we see. Blood levels, we are watching, it kind of depends on the type of anemia. When we're caring for these patients, what are we assessing for? We may see somebody that has anemia that's extremely pale. We may see someone who has very mild cases and they just don't have any symptoms. A lot of folks, though, with the more severe anemias have that paleness, fatigue, dyspnea, sensitivity to cold, tachycardia, dizziness, and syncope. So what we're really concerned about is their safety, because if you're very weak, if you're short of breath, if you are prone to fainting, all of those are safety concerns for the nurse. Nursing interventions are going to really focus on fixing the problem. We would like to encourage increased dietary intake, depending on your type of anemia. We want to monitor vitals, especially our O2, to determine if we need some oxygen therapy. We want to administer medications. A lot of those dietary supplements have very specific times of when they need to be given so that they absorb correctly. And we need to educate our patients to diet, to safety concerns, all of that. Patients may need to increase their iron, their B12, or folic acid. We may have to look at energy conservation and consider dizziness with standing and our risks of anemia. When somebody has anemia, we have to look at kind of the medication and treatments. These involve often, iron supplements, erythropoietin, vitamin B12, folic acid supplements, and even possibly a blood transfusion if it's really serious. So when we look at iron supplements, what do we need to teach our patients about iron supplements? If you have ever been on them, you probably have noticed that your stools turn black. Vitamin C aids in the absorption of iron, so it's good to take between meals to optimize absorption, and we want to check the hemoglobin level in 4 to 6 weeks to determine efficacy. Erythropoietin is a hormone. It increases that production of red blood cells. So we want to monitor for an increase in blood pressure, monitor the hemoglobin and hematocrit twice a week. Hemoglobin, if it increases too quickly, the patients could have a cardiovascular event, so we monitor for this as well. We don't want them to really increase by 1 gram in over 2 weeks. That's too fast. We need to look at our vitamin B12. It converts to folic acid. It converts folic acid to the active form. B12 can be supplemented orally if the patient simply lacks the dietary sufficiency. Now, if the person has pernicious anemia, which is the autoimmune version, they lack that intrinsic factor in the stomach, and it causes a malabsorption syndrome. So that B12 has to be given by injection because they're not going to absorb it orally. So more supplements doesn't fix anything. So those will be given either IM or deep sub-Q. And the patients will need therapy for life. The injections are typically given monthly. Folic acid supplements, these are definitely needed for the production of new red blood cells. Large doses can mask vitamin B12 deficiency and turn urine dark yellow. So before starting a patient on folic acid, we need to confirm that the patient doesn't have a B12 deficiency. Folic acid resolves the anemia, but neurological degeneration can occur because we don't have the B12. And blood transfusions, it does give kind of an instant fix, but it's only used for patients with significant manifestations because of the related risks. Remember, blood is very, very precious. So unless it's a severe case, they're not going to just be getting random blood transfusions. This is something that's reserved for very, very severe cases. Our goals of care involve avoiding complications and reducing fatigue. So patients should pace activities to reduce fatigue. We may also suggest a shower chair, bed bath. Make sure that they are taking breaks so that they're not getting too worn out. This is something we can do to hopefully avoid that extreme fatigue. Anemia can significantly impact the function and quality of the life of the patient. This disorder can adversely affect chronic health conditions such as CHF or chronic renal failure, as well as impair thermoregulation and increase immune dysfunction. Psychomotor abnormalities and cognitive impairment occur in children with IDA, impaired learning, and the ability of the child to function adequately. Iron deficiency anemia during pregnancy increases the risk for low birth weight, preterm labor, and perinatal and postpartum mortality of the infant and or mother. So this is not something that we should ignore because it does affect a lot of systems. Our nursing diagnosis involves the inadequate tissue perfusion, fatigue, and activity intolerance. We have to make sure our patients' ADLs can be completed safely. Think about your patient with dizziness and fatigue. Can they stand in the shower long enough to clean up safely? It could be a situation where they are very weak and very fatigued and they can't go to the toilet. So we need to think of how to help them be as safe as possible. Iron deficiency anemia has some very specific clinical manifestations. We absolutely see hypoxia, and as it increases, the patient may become increasingly short of breath. The body is compensating for the oxygen deficiency created by the low hemoglobin hematocrit. Iron deficiency anemia may also affect rapidly regenerating cells of the mucous membranes and the gastrointestinal tract, causing fissures in the corner of the mouth and or glossitis, which is painful swelling of the tongue. It makes it appear smooth and shiny because of the flattening of the lingual papillae. Spoon-shaped fingernails or koilonychias, are the result of severe prolonged iron deficiency, which renders the cells of the fingernails soft and malleable. The pressure exerted by ordinary functions, such as writing, causes the nails to become deformed. We see in the first picture there glossitis in the patient with iron deficiency anemia. We want to note the bright red tongue, the swelling, the shiny appearance due to the flattening of the papillae. And then the bottom picture, you can see the koilonychias in a patient with iron deficiency anemia. So we note the spoon-shaped and the thinness of the nail. Laboratory tests that we use to diagnose iron deficiency anemia will include our CBC and serum iron tests. We will see on these tests decreased hemoglobin and hematocrit levels. Low serum ferritin levels, which reflects the body's iron stores, are a confirmation of iron deficiency anemia. Serum ferritin levels of less than or equal to 100 units indicate the iron deficiency anemia 100% of the time. Additional diagnostic studies to confirm IDA include serum iron, total iron binding capacity, serum transferrin receptors, and mean corpuscular volume. So the iron studies, that means we're going to look at the total iron binding capacity, that indirect measurement of transferrin, the protein that binds with iron and transports it. Ferritin indicates the total iron stores in the body, but low blood iron and elevated TIBC, which is the total iron binding capacity, indicates iron deficiency anemia. Education will include dietary sources of iron, so what foods that are high in iron, signs and symptoms of bleeding, we want to report that right away. We want them to take daily iron supplements, the dangers of lead exposure, and prenatal teaching if that's appropriate. So our good sources of dietary iron are going to be red meats, green leafy vegetables like spinach, broccoli, and peas, beets, dried beans, iron fortified cereals and breads, and cream of wheat. We want to report any signs of bleeding, increased fatigue, or shortness of breath. These clinical manifestations present when iron stores have already been significantly decreased. We want to take a daily iron supplement as prescribed, but they have to be aware that they can cause constipation, diarrhea, nausea, or abdominal discomfort. Patients need to be instructed to report these side effects to the healthcare provider. If they're too severe, then we may have to switch to another route. So we are concerned again about lead exposure. A higher iron does make you more susceptible to lead poisoning. And then we want to consider prenatal teaching about iron intake. Inadequate iron intake by women has been linked to lower birth rate, preterm labor, and increased mortality of the mother and child. Vitamin B12 anemia, our clinical manifestations could be spinal cord degeneration, peripheral neuropathy, altered mental status, even something like depression, visual changes, and Lermet's sign. So the B12 deficiency, patients that have maybe GI resections, autoimmune disorders, long-term use of medications that decrease gastric acid secretions like PPIs or H2 blockers, they're at higher risk. So B12 is only found in animal proteins. So low socioeconomic status and long-term vegetarianism and veganism increase the risk of insufficient vitamin B12 intake. We're not trying to discourage these diets. Most people that are vegetarians and vegans feel very passionate about their lifestyle choices, and we need to support that, but we also say, hey, we need to get some supplements so you're not going to be deficient in B12. So, certainly, support the diet and their choices, but let's help keep them healthy. If they do have a vitamin B12 deficiency, any of your patients, this can cause neurological and psychiatric dysfunctions. It can cause demyelination of the nerves. And so this is one of those disorders that needs to be ruled out before MS can be diagnosed. This can lead to spinal cord degeneration, peripheral neuropathy, altered mental status, and sometimes depression. Visual disturbances may occur as a result of nerve atrophy in the eyes. Lermet sign, that is a sudden electrical shocking sensation that goes from the neck down the spine, and this can occur with our vitamin B12 deficiency. So when we suspect vitamin B12 anemia, our diagnosis is going to be that history and physical and some laboratory tests. Treatment is going to be prevention and B12 injections. And we want to address complications, any impaired functional ability. So we can look at the Schilling's test that measures our B12 absorption. It differentiates between malabsorption and pernicious anemia, and this can kind of decide what treatment is used. So remember, with pernicious anemia, because they don't have that intrinsic factor in their stomach, they can't absorb the B12 that they're eating from their diet. So then if they take a pill for B12, it's not going to do anything. You have to have the injection. Now, if you have a malabsorption issue because you're not, you don't eat enough B12 because you have a very special diet, or if, for whatever reason you're not eating enough so that you are fulfilling your need for this, you could definitely take a pill version of B12 and it would be absorbed, but it just depends on why, and they have to decide what, why is this happening. So prevention of B12 deficiency is important, and animal proteins provide the only source of vitamin B12 in the world. It hasn't been discovered in any plants. So dietary sources of B12 include meat, seafood, eggs, and dairy products. Long-term vegans and vegetarians, those people with low socioeconomic status, these are at an increased risk of deficiency. Oral supplements of B12 may not be sufficient once the deficiency is found. And the patient, they have developed clinical manifestations like fatigue, weakness, and paresthesias. So once severe deficiency is determined, weekly vitamin B12 injections are required. So if it's really severe, let's do the injections. It's going to help them and fix the problem a little faster versus the oral medications, because we know, again, first pass effect is in effect anything we take in orally. So for severe B12 deficiencies, they're going to prescribe the weekly B12 injections. So we want to tell people about the dietary sources of B12, like meat, seafood, eggs, and dairy products. We need to address those that have special diets, those vegans and vegetarians that may need daily oral supplementation. We want the patient to report any clinical manifestation of fatigue, shortness of breath, paresthesias, and confusion. Resolution of the anemia doesn't necessarily stop neurological degeneration unless the deficiency is resolved. Prenatal teaching, we want to have them understand that pregnancy may increase the demand for vitamin B12, so prophylactic oral supplementation is recommended. Folic acid, very important. It can relieve the signs and symptoms, but the neurological deterioration will continue. We need to have them know nitrous oxide activates vitamin B12 in the body. So prior to using that for anesthesia, we have to make sure that the patient is not B12 deficient. Sometimes radiation for advanced cancers, patients with anemia do not respond as well to radiotherapy because of impairment of oxygen transport to cancer cells. And we have to kind of look at those acid-reducing medications. Do they have to be on the PPI or the H2 blocker, because it's going to prevent them from absorbing very important vitamins and minerals, including our B12. So when we look at folic acid deficiency, the patients at risk are older adults, those with chronic illness, those that have alcohol abuse, and extreme diets. Folic acid deficiency is usually the result of inadequate dietary intake. So patients with rheumatoid arthritis who are treated with methotrexate may develop folic acid deficiency secondary to the antagonistic effects of this medication to folic acid. This complication may be managed with folic acid supplementation. Dietary sources of folate include green leafy vegetables, bran, yeast, legumes, and nuts. It is essential to differentiate between folate deficiency and a vitamin B12 deficiency. Folic acid deficiency may also cause neurological, clinical manifestations such as confusion or disorientation. However, unlike a vitamin B12 deficiency, these clinical manifestations are reversible and resolve with the resolution of the deficiency. A CBC confirms the diagnosis of anemia with decreased hemoglobin levels. However, a specific etiology of the anemia must be identified. Serum MMA and homocysteine levels are the best laboratory tests used to differentiate between anemia caused by folic acid deficiency and those secondary to a vitamin B12 deficiency. Dietary sources of folate or folic acid include fortified cereals, grains, legumes, green leafy vegetables, bran, yeast extracts, and nuts. Immediately report any clinical manifestations of fatigue, shortness of breath, dizziness, and confusion. Resolution of anemia through supplementation or blood transfusion may be needed to increase tissue perfusion. Prenatal teaching, we want to let our mom-to-be know that folic acid deficiency and the occurrence of neural tube defects and orofacial abnormalities occurring during that embryonic development, these are linked. So we're concerned that they may have these unintended consequences and very, very severe because of these deficits. So definitely let our patient know that they have that need for supplementation, and individuals at risk need to be educated on, how to take their supplements, how can they add it into their diet, and how important it is to address this anemia. So next we're going to move on to sickle cell anemia. Sickle cell is the most severe form of the inherited blood disorder. It is when our cells, instead of being nice and round and flexible, they are more like jagged and moon-shaped, meaning they're firm and they don't move around very well. So they get stuck in our little tiny vessels and cause a lot of pain. So sickled RBCs carry less oxygen and they're very fragile and they tend to lyse quickly. The hemolysis leads to anemia. Abnormal cells clump and form thrombi. The clinical manifestations of the patient with sickle cell anemia, they do have anemia, they have vaso-occlusion, which causes a lot of pain and swelling. So when it comes to sickle cell anemia, the red blood cells become elongated and stiff. They lose their flexibility and are sickle-shaped, like I said, kind of a moon-shaped. The result is congestion and clumping in the capillary beds and the formation of thrombi. Although the normal lifespan of a red blood cell is 120 days, in an individual with sickle cell anemia, the normal lifespan of those cells is 15 to 20 days. Destructions of the red blood cells also release bilirubin, causing a rise in the serum bilirubin level, so these patients can become jaundiced. There's a possibility of congestion of these cells in the spleen, which leads to an enlarged spleen and possible pain. When the sickling process is rapid and severe, the patient has a sickle cell crisis. And there are 4 types of these crises. Vaso-occlusive, which is the most common type. It's very painful, caused by the obstruction of vessels by hemolyzed cells, leading to tissue hypoxia and pain. There is an aplastic crisis in which the bone marrow ceases to produce red blood cells with subsequent decrease in the blood reticulocyte count. There is a sequestration crisis caused by a sudden massive pooling of RBCs in the spleen with resulting hypovolemic shock and cardiovascular failure. There's also a hemolytic crisis. So this results from that increased rate of RBC hemolysis with resultant decreased hemoglobin levels and increased jaundice. So the sickle cell crisis, most often precipitated by anything that causes hypoxemia, increasing vasoconstriction and sickling of the RBCs. Precipitating factors include dehydration, cold temperatures, infection, and environments with low oxygen tension, such as depressurized airplane cabins in high mountains. Crises may appear without any apparent reason and usually last several days to a week. They may occur frequently for a period of time and then become dormant. Sickle cell crisis presents like anemia, with fatigue, pallor, and shortness of breath, and then vaso-occlusion of the blood vessels resulting in pain and swelling. Pain occurs usually in the joints, bones, chest, and abdomen. Ischemic organ damage secondary to the vaso-occlusion causes cerebrovascular and pulmonary and splenic infarctions. Priapism in males, which is a prolonged and painful erection. Kidney and liver damage. Fever may be present even in the absence of an infection. Wound healing is delayed, and these patients have an increased risk of developing infections, particularly respiratory infections. Repeated episodes of crises and infarctions of the bones can lead to uneven development of the fingers and toes, known as hand-foot syndrome, which is characterized as swelling of the dorsal surfaces of the hands and feet causing pain. Pregnancy, with its increased demand on the body, can cause an exacerbation of sickle cell disease. Death is usually the result of a CVA infection or long-term organ system damage. There is no cure for sickle cell disease, and treatment is aimed at the prevention of crises and symptom management during a crisis. Long-term management is aimed at minimizing complications and organ dysfunction. During a crisis, oxygen therapy is implemented to reverse the hypoxia caused by decreased hemoglobin and vaso-occlusion of vessels. Aggressive hydration, both oral and parenteral, increases blood volume and reduces renal vaso-occlusion. Analgesia, usually opiates, is administered for severe pain. Alternative and complementary treatments for pain management can also be taught and employed by the patient to minimize the use of strong analgesics. Antibiotics for infection are also initiated. An exchange for blood transfusion, which is the entire blood volume it's exchanged, is also a treatment performed on many patients with sickle cell disease. The goal of this treatment is maintaining the sickled hemoglobin to no more than 50% of the total hemoglobin in order to prevent or delay thrombotic episodes, including CVA. The bone marrow will still produce sickled cells, so exchange blood transfusions are not a singular treatment. Patients receiving repeated exchanges have an increased risk of blood transfusion reactions and iron overload. Complications are related to the intermittent episodes of hypoxemia, thrombus formation, and tissue hypoxia, resulting in infarction and necrosis. So our nursing diagnoses, we look at impaired tissue perfusion related to sickling of RBCs with the resulting decreased oxygen carrying capacity and tissue hypoxia. We have activity intolerance related to hypoxemia resulting from the sickling RBCs. There's acute pain related to those clumping of the sickled RBCs in the capillary beds, resulting in tissue ischemia. A risk for powerlessness is related to the frequent sickling cell crises, often for no apparent reason. So we're going to do some assessments for our sickle cell patient. We're going to look at our vital signs, looking at tachycardia and tachypnea. We're going to look at fatigue, pallor, and shortness of breath. We know that that decreased level of hemoglobin, the decreased level of RBCs, there's going to cause inadequate tissue perfusion and hypoxia. We're going to look at the pain and swelling in joints and extremities. Pain is caused by that tissue hypoxia and the clumping of cellular debris, particularly in the joints, bones, chest, and abdomen, leading to vaso-occlusion. We're going to evaluate for jaundice. This is the decreased lifespan and increased destruction of RBCs, and it may cause that increase in serum bilirubin, leading to jaundice. We're going to evaluate for hand-foot syndrome. Multiple episodes of crises and bone infarctions may lead to uneven growth in the fingers and toes. And we're going to look at the clinical manifestations for infection. Fever may be present without an infection. However, infection must be ruled out. X-rays are going to be used to eliminate pneumonia or osteomyelitis. Skin lesions must be assessed for infection. We're also going to evaluate dental hygiene because this can't be overlooked as a source of possible infection. Laboratory tests are going to be the hemoglobin and serum bilirubin levels. Sickle cell RBC cells have decreased hemoglobin levels and increased hemolysis of the RBCs. It's going to elevate those serum bilirubin. We're going to look at serum iron, vitamin B12, and folate levels. A lot of times people that have sickle cell disease also have decreased levels of iron, vitamin B12, and folic acid. These deficiencies complicate the anemia and need to be corrected. Let's also evaluate psychosocial issues. These patients may have anger or depression in response to chronic disease, frequent absences from work. It can interfere with employment, leading to feelings of guilt or anger. The interventions are going to be to administer oxygen. This oxygen assists in decreasing hypoxia and minimizing the severity of the crisis. We're going to provide aggressive hydration. It is increasing the blood volume, easing the clumping of the debris in the capillaries and flushing the kidneys, minimizing the risk for renal failure. We're going to administer pain medication. Analgesia, usually opioids, is going to help manage the pain caused by vaso-occlusion. We may have to do blood transfusions, administer maybe antipyretics if there's a fever, provide supportive measures. It's very frightening to all people, so the nurse needs to provide emotional support and be cognizant of the possible issues. So the priority with these patients is going to be administering oxygen and managing pain. So our patient education is going to involve the pathophysiology of the disease, infection prevention, avoiding cold temperatures, avoiding high altitude, avoiding dehydration, avoiding overexertion, maintaining activities of daily living, understanding that pregnancy is going to make the risk of a crisis much higher, fetal complications, and genetic counseling. It's probably most important to avoid overexertion. We're going to have to take rest periods. Our patient is going to have to take it and avoid undue stress on the cardiovascular system. Maybe you want to consider, is it safe for these patients to play competitive sports? So hopefully that's an obvious no. We don't want them to overexert. We don't want them to get dehydrated. All of that could make a crisis come on. Damage to the bone marrow results in decreased production of red blood cells, white blood cells, and platelets in aplastic anemia. If there's also decreased erythrocytes, granulocytes, and platelets, the condition is known as pancytopenia. The exact cause of aplastic anemia is not clearly understood, but exposure to infectious agents, chemicals, and other insults to bone marrow leads to a cellular immune response. The result of this response is the production of cytokines that suppress both stem cell growth and development. Clinical manifestations are as with other anemias, and these patients are susceptible to infection and bleeding as well. ABC results reveal pancytopenia, so all counts are low. Due to the potential for thrombocytopenia, coagulation testing is important to evaluate the risk of bleeding. During the diagnostic evaluation phase of aplastic anemia, blood transfusions are a primary treatment. However, the goal of treatment is to minimize transfusions to decrease the sensitization that ultimately increases the risk for bone marrow transplantation rejection. The preferred treatment for aplastic anemia is bone marrow transplantation from an HLA-matched sibling donor. Other treatments focus on stimulating bone marrow with medications such as Neupogen and Epogen, which stimulate the bone marrow production of cells and relieve symptoms. In patients over the age of 60 and those without an HLA-matched sibling donor, immunosuppressive therapy is preferred. Aplastic anemia has a mortality rate of greater than 70%, and these patients are at increased risk for complications associated with pancytopenia. When we look at our nursing diagnoses, we have activity intolerance that's related to the decreased oxygen carrying capacity secondary to decreased red blood cells. We also have a risk for injury related to decreased platelets secondary to bone marrow suppression, and risk for infection related to decreased white blood cells secondary to bone marrow suppression. So as we're looking at this, we have our decreased cellular and tissue perfusion, a very high risk of hemorrhage, and a high risk of infection. So what do we do for our aplastic anemia patients? We provide supplemental oxygen, we administer blood products, we implement bleeding precautions, and we protect them from injury. These patients have decreased white blood cells. The patient is at risk for infection, so crowded places should be avoided. Report all temperature elevations. Patients with aplastic anemia may present with a low-grade temperature with an infection due to bone marrow depression that impacts white blood cell production and maturation. To avoid activities with the potential for trauma or injury. Potential trauma and injury increase the risk of bleeding due to thrombocytopenia. With the clinical manifestations of anemia, we have to look that aplastic anemia is a medical emergency. The patient and the family need to be instructed to contact a healthcare provider at the first signs of anemia, infection, and bleeding. Nutritional intake, we have to make sure that we are getting good nutrition because it enhances our immune function and our resistance to infection. We're looking at positive outcomes, meaning that they have a stable CBC and platelet count with the absence of infection and bleeding. As tissue perfusion improves, we should see the clinical manifestations of tachycardia, shortness of breath, fatigue, and pallor. We should see those resolve. So look at this question, prioritizing patients. I want you to pause this and then think of your answer, and then we'll go over it. So the answer will be B as in boy. The rationale is that the elevated heart rate is seen as a compensatory mechanism in patients with anemias or other hematological disorders, and this may affect that oxygen carrying capacity. So an increase in menses requires evaluation, but it's not the priority. Patients on Coumadin routinely come in for an evaluation of their PTT. So, unless they are complaining of increased bleeding, this wouldn't be a priority. And a slight decrease in serum iron is a normal finding in adults over the age of 60. So our priority is going to be the 35-year-old patient complaining of racing heart. There are numerous causes for thrombocytopenia, including malignancy, infection, certain medications like sulfameds, autoimmune conditions, and DIC. So idiopathic thrombocytopenia purpura, this is the platelet destruction is increased rather than that 7 to 10 day lifespan. Platelets may be destroyed in a matter of hours. Clotting factors are lacking in things like hemophilia. This interferes with normal clotting mechanism of the bodies. The two most common forms are hemophilia A, which is a factor 8 deficiency, and hemophilia B, which is a factor 9 deficiency. There can also be a heparin-induced thrombocytopenia. It typically occurs 5 to 14 days after the first administration of heparin. Antibodies initiate a response that culminates in the formation of new blood clots and a resulting fall in a platelet count as they are consumed, used up to form these thrombi. So what would indicate that the HIT is resolving? And that would be our platelets are increasing. So what do we see with thrombocytopenia? We see decreased platelets, easy bruising, petechiae, and bleeding. This bleeding may occur from the nose, around the gums, or from the GI tract. In severe cases, bleeding in vital organs such as the brain may prove fatal. So what do we see with thrombocytopenia? A diagnosis of thrombocytopenia equals platelets less than 150,000. In addition to the CBC, bone marrow biopsy can confirm the diagnosis of ITP, idiopathic thrombocytopenia. So we're looking at prolonged prothrombin time, partial thrombin time, and thrombin time. These are very helpful in diagnosing DIC, as well as reduced fibrinogen level, elevated fibrin split products, and elevated D-dimers. So we're going to look also at clotting factors. We may use a blood smear in determining the morphology of the platelets. In addition, to the CBC to diagnose HIT, there's an enzyme-linked immunosorbent assay, the ELISA, which is an immunoassay test to determine the presence of antibodies. In extreme cases, performing a splenectomy has improved platelet counts because the spleen is the primary site of platelet destruction. In hemophilia cases, depending on the type of hemophilia, replacement of the missing clotting factors is indicated, and these can be administered intravenously. Resolution of the underlying condition that initiates the clotting cascade is imperative. So we definitely want to administer immediate antibiotic therapy to treat sepsis, providing supportive care like in administering blood, platelets, fresh frozen plasma, and cryoprecipitate. These things might be all used to provide like a hemostasis. These patients are managed in an intensive care setting where they can be closely monitored with hemodynamic monitoring equipment. Mortality rates are high in patients who develop DIC, although the exact numbers are not known because the cause of death is usually attributed to the underlying disorder. So we're going to stop the heparin. That's the first step in treating HIT. However, because the formation of additional thrombi occur frequently in these patients, an anticoagulant is required to prevent further thrombi formation and the production of the antibodies. Following the platelet count, we're going to will help us see if they're recovering. So warfarin should not be used because it can cause skin gangrene in this population. 3 anticoagulants have been approved in patients diagnosed with HIT, and that's a deniperoid, lepirudin, and agatroban. Platelet transfusions are discouraged because they may increase thrombus formation. Risk of hemorrhage is a major complication of any condition that results in thrombocytopenia, and the severity of the thrombocytopenia determines whether there is a risk of spontaneous bleeding. Transfusion of platelets is usually not given until the platelets are less than 20,000 because of the risks involved with blood product transfusions. However, if an invasive procedure is being considered, transfusions may be given prophylactically to minimize the risk of bleeding. Close monitoring is indicated in patients with any type of severe trauma in order to detect early manifestations of DIC, because early recognition of thrombocytopenia is key in determining the patient's prognosis. Clinical manifestations of thrombocytopenia are a result of the decreased number of platelets. What symptoms would you expect to find when a patient has low platelets? Ecchymosis, petechiae, frank bleeding, meaning nosebleeds, bleeding gums, black starry stools, or hematuria. Parts of the body where the mucous membranes are thin or cells rapidly divide are more prone to bleeding when platelet counts are decreased. So the risk of injury really is determined, it's related to how decreased the platelets are. We are going to look at that diagnosis, nursing diagnosis, the risk for ineffective therapeutic regimen management related to possible frequent administration of platelets or clotting factors. And the other nursing diagnosis, fear related to hemorrhaging from a low platelet count. So all of these are like our nursing diagnosis: risk for injury, risk for ineffective therapeutic regimen, fear, risk of bleeding. Our nursing interventions are going to include implementing bleeding precautions. We're also going to want to minimize blood loss from lacerations or venipuncture. If bleeding occurs, apply direct pressure under application of ice to cause vasoconstriction to stop bleeding. This includes direct pressure on sites after blood draws, venipuncture, and different procedures. We want to avoid IM. IM injections can cause bleeding into the muscle, and the bleeding can be very difficult to manage. We want to avoid rectal temperatures, enemas, suppositories, and douches. These procedures can tear thin mucosa of the rectum, anus, and vagina, leading to bleeding. We also want to make sure the patient is not straining while they defecate. So how do we ensure that? How do we ensure that they're not straining? So this would be a good time to use our daily stool softener. Provide a safe environment. We want to keep the patients clutter-free to minimize patient injury that can lead to bruising. And if we're going to do a blood pressure, we need to use minimal inflation when assessing, because that overinflation of that blood pressure cuff can cause bleeding. So we only want to inflate the cuff until we can't hear the pulse anymore, and avoid automatic blood pressure cuffs, because again, they're going to get pretty high and would cause bleeding. Those that have this issue, we definitely want to make sure we're keeping blood draws to a minimum. It is very common that we just draw way too much blood when we're in the hospital, and we cause people problems. So whatever tests need to be run together with a minimum amount of blood. Here are some of our bleeding precautions. Please review this slide. Should be information you covered in semester 5, but definitely review it. You will see it again. Here's a list of bleeding precautions for the patient that has thrombocytopenia or bleeding disorders, and please review this. Patient education that comes with our bleeding precautions. We need to instruct the family and friends on the bleeding precautions, teach patients how to minimize bleeding. It helps them function with thrombocytopenia or bleeding disorders, and to minimize the risk of hemorrhage. We want to instruct the patient to avoid sexual intercourse when the platelet count is less than 50,000. Sexual intercourse during periods of extreme thrombocytopenia can tear mucous membranes of the vaginas or rectum, causing hemorrhage. We are going to have frequent testing just to monitor the thrombocytopenia, and the goal of patient care is really to prevent hemorrhage. The key to managing thrombocytopenia in any of these disorders is to provide supportive care and to treat the underlying condition. Close surveillance is required, along with the administration of specific medications or blood products to minimize the risk of bleeding. Patients must demonstrate an understanding of the nature of the condition and the importance of performing interventions to minimize bleeding episodes. And this also includes GI bleed patients. We're going to monitor the hemoglobin during active bleeding to see if and when they need a transfusion. This case study, Marge Starr, high school physical education teacher who has noticed she is having increasing difficulty performing her teaching responsibilities. She schedules an appointment with her nurse practitioner for an evaluation of her symptoms. So we want to take a look at that EHR and find the relevant data. So she states that she needs to take a nap after work because she's very tired. HR, the heart rate, the respiration rate, blood pressure, and O2 are on the low end. Pale, cool, dry skin, red edematous, smooth tongue. She does have a vegetarian diet with no supplements. Based on the relevant data in the EHR, what tests and assessments do you anticipate? So you can pause this for just a second and think about what kind of testing you would like to see. So she will be getting a CBC with DIF, iron studies, and a nutritional assessment. So these are her lab levels. The laboratory results are for the RBCs, the hematocrit hemoglobin. We see that they are pretty low, and then combining this with the vital signs and how she's feeling, what disorder do you think she has? The low hematocrit and hemoglobin, low ferritin levels, all of these combined with the general fatigue, shortness of breath, the red swollen tongue, all of it is pointing towards iron deficiency anemia. So she is prescribed iron supplements and referred to a hematologist for further evaluation. Honestly, probably for just anemia, they would probably start her on iron supplements and test her again in a few months. I don't think they would go quite to a hematologist yet. But, in order to be, extremely careful, then maybe that's what these guys did. But we would definitely want to evaluate her, in 6 or 8 weeks to see if her symptoms are improving. Now we're going to begin talking about leukemia. 4 major leukemias are the AML, which is that acute myelogenous leukemia. We've got chronic leukemia, which is CML, acute lymphoblastic leukemia, ALL, and then the chronic lymphocytic leukemia, CLL. Now, these are not something we expect you to have a mastery of all cancers. We're just going to kind of touch on them and see, what kind of symptoms we'll see and what kind of nursing interventions we need to perform. A lot of these, the AML and the ALL have acute sudden onsets, even though CML and CLL may be present for years. They do eventually degenerate into an acute phase and progress to death if untreated. So the exact cause is unknown, but exposure to toxins is thought to increase the patient's risk of leukemia. So clinical manifestations. We see here a normal hematopoiesis compared with the development of leukemic cells. Unknown stimulus mutates the myeloid or lymphoid stem cells. We have an uncontrolled proliferation of leukemic cells. Apoptosis, which is that programmed cell death, does not occur. Bone marrow, spleen, lymph congestion with all the blasts. Since the white blood cells don't mature, the patient can become neutropenic and more susceptible to infection. Major infections cause profound neutropenia, where the absolute neutrophil count is less than 1,000. These patients are on neutropenic precautions, which includes no fresh flowers, filtered water only, no raw fruits or vegetables, avoid large gatherings, no sick visitors, and all visitors should wear masks. As leukemia progresses, the bone marrow, which is congested with leukemic cells, is not able to adequately produce red blood cells and platelets. Patients often present with clinical manifestations of anemia, as well as symptoms of thrombocytopenia, so we will see decreased hemoglobin, hematocrit, and platelets. Patients often present with a low-grade fever in response to exposure to organisms that the immune system can usually handle. Leukemia left untreated is fatal, with infection being the primary cause of death. Diagnosis. So often a patient is going to present to the healthcare provider with complaints of a flu-like symptom like fatigue, low-grade fever, and pallor. But sometimes the leukemia is completely asymptomatic, and a routine CBC reveals that that's what they have. So it will reveal the leukocytosis or an increased white blood cell count, but it also demonstrates anemia and thrombocytopenia. Confirmation of the diagnosis of leukemia is usually followed by a bone marrow biopsy that shows what type of leukemia and the extent of the malignancy. Genetic testing can be performed on these cells to determine if there's any chromosomal abnormalities. So these folks will probably get chemotherapy, and our side effects, again, nausea, vomiting. And if our patient comes in for chemo and they know they'll have nausea and vomiting and they inform you of this, what are you going to do? We certainly want to pre-treat people, give them an antiemetic before it occurs, and call that physician if you don't have orders for that. So transplantation is currently the only possibility of a cure from leukemia. Previously, bone marrow transplantation was the only type, but now they do a peripheral stem cell transplantation or a hematopoietic stem cell transplantation, and those are used. There are some potential graft versus host diseases that you have to be aware of and educate the patient on the symptoms of. But even if they do have a transplantation, there is the possibility the leukemia can return, causing a relapse. Complications of leukemia are usually the result of the treatment for the disorder and the myelosuppression that occurs after chemotherapy or radiation. The disease itself may eventually be fatal as a result of infection or hemorrhage. The best chances of remission and prolonging life are specific treatments. A fever is called a neutropenic fever when a patient's ANC is less than 1,000. Patients are instructed to institute neutropenic precautions because this is a dangerous situation for the patient. Immediate interventions like that administration of the IV antibiotics is indicated for patient survival. Nursing interventions will involve administering chemotherapy as prescribed. The patient is started on chemotherapy to destroy the leukemic cells. Nurses are going to institute neutropenic precautions if needed. The patient needs to take extra precautions to prevent infection due to a low neutrophil count. We're also going to have the prophylactic use of antibiotics, antivirals, and antifungals as ordered. We're going to administer IV antibiotics, especially if the ANC is less than 1,000. It's imperative to start IV antibiotics immediately in order to prevent sepsis and possible death. Our symptom management is going to be really important. We want to make sure that we are fixing what we can and making people feel more comfortable. We want to address things like nausea, vomiting, diarrhea, and ulcerations of the mouth. We definitely want to make sure that their quality of life is good, and we do that by managing our symptoms very well. Untreated leukemia is a fatal disorder. The goals of treatment are to induce remission for the patient and to minimize or prevent complications. Treatments are considered effective when the patient has decreased clinical manifestations of anemia, infection, and bleeding. Proof of this would be improvement in labs like your hemoglobin, hematocrit, white blood cells, and ANC, platelets. Prolonging life and improving the quality of life are important considerations in treating patients with leukemia. Symptom management of chemotherapy and radiation therapy aids in improving the quality of life. At present, a bone marrow transplant or stem cell transplant is the only chance of achieving a cure for leukemia. This is a slide on neutropenic precautions. It's something you probably should have gone over in 5th semester, but please do review it so that you can remind yourself of what those neutropenic precautions are. Hodgkin's lymphoma accounts for approximately 14% of all lymphomas and has a higher survival rate than non-Hodgkin's lymphoma. The incidence of all lymphomas occur more in men than women. Non-Hodgkin's lymphomas represent approximately 4% of total cancer incidences and account for 4% of cancer-related deaths. Hodgkin's lymphoma peaks in two age groups, usually teens and young adults, or adults in their 50s and 60s. They believe it's possibly related to viral infections or exposure to chemical agents. Usually starts in a single node, and these have the Reed-Sternberg cells, and they spread predictably. This is one of the most treatable cancers. Non-Hodgkin's lymphoma is more common in men and older adults. These are these lymphoid cancers that don't have that Reed-Sternberg cell. It has a very erratic spread. They think this is related to either gene damage, viral infection, autoimmune disease. And there's an increased incidence of this occurring in people that have been exposed to pesticides, insecticides, and dust. So when we talk about malignant lymphoma, we need to talk about the clinical manifestations. The involvement, has major organ groups, may also cause further clinical manifestations that individuals can cause them to seek medical attention. Clinical manifestations of shortness of breath and a feeling of fullness may occur as enlarging lymph nodes spread to the spleen or liver and compress the vena cava or spine. It's very important for you guys to remember these manifestations: the painless swelling of lymph nodes, low-grade fever, night sweats, unexplained weight loss, and fatigue. With the malignant lymphoma, the diagnostics will occur after, the history and physical laboratory testing, possibly chest x-ray, CT, PET scan, MRI. The lymph node biopsy usually provides a definitive diagnosis. A CBC may show evidence of bone marrow involvement and possible anemia with an abnormal white blood cell count. If the bone marrow involvement is suspected, they may order a bone marrow biopsy, and then possibly a lumbar puncture is performed if the central nervous system is involved. Treatments involve chemo, radiation, removal of the tumor or removal of the spleen, and stem cell transplant. There are some complications we need to be aware of. Vena cava syndrome, which blocks and compresses the vena cava. Spinal cord compression and hypercalcemia. These are considered oncological emergencies. Individuals who develop these conditions need immediate medical attention. Splenectomy may be necessary in some patients because of the splenic involvement. So either as a primary site or something that is metastasized from the tumor. But we need to be aware of these, that these are very important to be aware of so that we can get people immediate help. What are some of the nursing diagnoses we consider when treating this population? Risk for infection is related to bone marrow involvement and the adverse effects of treatment. Activity intolerance is related to anemia caused by bone marrow involvement. Risk for ineffective coping related to diagnosis and lifestyle changes that are needed to accommodate treatment. Our nursing interventions are going to include the administering of blood products, mostly because we need the blood count fixed because our counts are dropping because of myelosuppression. We need to administer our chemotherapy agents. This is the primary treatment for lymphoma. We need to administer IV fluids as prescribed. The IV fluids are, really important because we may have a lot of fluid loss secondary to fevers. We also may have hypercalcemia, and the increased fluids will help wash away the calcium so it doesn't lead to kidney stones. We need symptom management, especially because they're on chemotherapy and radiation. Excuse me. We also need to obtain CBCs because myelosuppression can be the result of the chemotherapy or radiation therapy. So hemoglobin and white blood cell counts are needed, and we have to monitor them closely. We also need to provide emotional support. Cancer diagnosis is very intense, and it's something that we need to help people deal with the fears of death and dying, and refer them to needed resources that they can maybe find some support through, support groups or organizations that, specialize in this kind of treatment and therapies. We have to go over patient education. We have to educate our patients to the disease process, how to manage the condition. When they understand how to manage the condition, it will improve compliance. We have to educate them about the risk of infection, how to maintain our treatment schedules and the importance of maintaining our treatment schedules. We need to encourage frequent rest periods. There's going to be some fatigue resulting from that anemia. Again, we've got that bone marrow involvement and myelosuppression, so it's not uncommon that they'll have fatigue. We need to address dietary intake to maintain adequate nutrition. We have to educate the patients to the clinical manifestations of potential complications, and when they need to be seeking medical attention. If they have shortness of breath, if they have edema, especially on the face and the arms, if they have chest pain, fever, especially if they're neutropenic, all of this may indicate complications. We also have to educate them to the potential for sterility. So chemo or radiation can cause a patient to be sterile, and those that are in their childbearing years may need to be educated about alternative ways of conceiving, including sperm and egg banking. Multiple myeloma is another type of cancer, and we'll look at old crab, old age, calcium elevated, renal failure, anemia, bone lytic lesions. This is an incurable B-cell malignancy. We've got some risk factors there. Lifetime risk for the individual living in the United States is about 0.8%. So our clinical manifestations have 6 cardinal features: lytic bone disease, the presence of a monoclonal antibody protein referred to as the M protein, anemia, renal insufficiency, hypercalcemia, and an infectious diathesis, or a tendency or predisposition to infection. I would be aware of these clinical manifestations. I would know these because you may see them again on an exam. So our diagnosis and treatment is, again, very similar to what we've seen before with the other cancers. They need lab tests. We need to look at the bone marrow, look at the skeleton. This one, we're going to do some bone density measurements. Our treatment: biphosphonates, radiation, DVT prophylaxis, dexamethasone, which is a steroid, stem cell transplant, and some chemotherapy. Our complications are going to be dealing with the side effects of chemotherapy, anemia, bone marrow failure, bleeding, infection, pathologic fractures, spinal cord compression, and hypercalcemia. As the disease progresses, complications develop secondary to the underlying pathophysiology, as well as to some of the treatment approaches, such as the side effects of chemotherapy. Let's consider some of our nursing diagnoses, like pain, impaired physical mobility, risk for infection, risk for injury, impaired urinary output, and fear. Our patient education involves reporting fatigue, shortness of breath, dizziness, confusion, sudden onset of pain, changes in sensation. And because of pain is a consideration, we always have to consider non-pharmacological pain management ideas. Our last slide involves a case study practice. There's a website included, so please, after you get done listening to this, go and follow this Davis Advantage link so that you can work through the case study, and will help you get a fuller understanding of the topics we've covered. Thank you.